Assalamu alaikum class. My name is Aman Hashmi and topic for my presentation is tobacco use and dependence. The books that I have taken the material from the clinical use of drugs, Koda Kimball and a pathophysiologic approach by DPO. Moving towards the objectives, we will discuss a brief introduction of tobacco and nicotine, tobacco cessation pharmacotherapy, case-based application of tobacco cessation products and pharmacist role in dealing with the tobacco cessation. What is tobacco? Tobacco is a plant that contains whose major constituent is nicotine, which is a mind-altering drug, and it provides euphoria when it comes into the bloodstream. It provides euphoria, enters into the brain, and relaxing effects to the body. It could be in smoking and non-smoking form. These forms will be discussed by my another group member. Moving towards the components of tobacco. Tobacco contains tar, nicotine, and carbon monoxide. Nicotine is an addictive substance that provides relaxing and calming effects to your body. Tar is a black sticky material which sticks to the lungs and causes it to lose its elasticity, whereas carbon monoxide does not allow hemoglobin to bind with oxygen and thus decreasing the oxygen capacity in the body. Toxic chemicals include benzene and formaldehydes. What happens when we use tobacco? Either we inhale tobacco, we chew, or whatever form we take tobacco, it enters into the bloodstream. Either it is absorbed through the lungs or through the membrane. When it enters into the bloodstream, it crosses the blood-brain barrier, enters into the brain, and as it enters to the brain, it binds to the nicotinic acetylcholic receptors. Nicotinic receptors are present in the brain, and as it binds to the nicotinic receptor, it triggers the release of dopamine, which is a neurotransmitter in the brain associated with the pleasure, and initiates the brain reward pathway. Uh, effects of nicotine addiction on brain. So when we talk about the withdrawal symptoms, so what are the areas that are most affected in the during the withdrawal symptoms of the nicotine? It is the prefrontal cortex, nucleus accumbens, and cerebral cortex, whereas the hippocampus has increased risk of drug abuse. What is nicotine? Nicotine is a toxic, colorless, or yellowish oily liquid which is the chief active constituent of tobacco. It acts as a stimulant in small doses, but in larger amounts blocks the action of autonomic nerve and skeletal muscle cells. It has different physiological effects on different organs, like in CNS, it provides pleasure, reward, arousal, improved concentration, and anxiety relief. While on heart, it causes arrhythmia, and other effects are appetite suppression, increased metabolic rate, skeletal muscle relaxation. Then nicotine pharmacokinetics. Nicotine is absorbed. Its absorption is pH dependent. First thing, then it is poorly absorbed in acidic media and well absorbed in alkaline media. Buccal cavity has a pH of 7, so it is well absorbed to the buccal cavity. Significant absorption of pipes, cigars, spit tobacco, oral nicotine products, skin. स्किन से भी ये बहुत अच्छा एब्जॉर्ब होता है, जीआई ट्रैक्ट से भी एब्जॉर्ब होता है, लंग्स से भी निकोटीन इज रैपिडली एब्जॉर्ब्ड अक्रॉस रेस्पिरेटरी epithelium because lungs has pH of 7.4, that is alkaline pH. Now, plasma nicotine concentration in arterial distribution and venous distribution. Arterial distribution, you can see here the graph, and in the venous distribution, it maintains a steady state in several minutes. So nicotine reaches the brain within 10 to 20 seconds. Nicotine metabolism, it is highly metabolized by CYP2A6, primarily metabolized to cotinine. Cotinine is the first metabolic product that is formed from the nicotine. 70 to 80% cotinine is formed, 10% other metabolites are formed. Nicotine is excreted through the kidneys. pH dependent excretion होती है इसकी, increases with acidic pH. Half-life of nicotine is 2 hours, while half-life of cotinine is 16 hours. Half-life of 14 is 16 hours. Now, nicotine dependence assessment. If we want to check the patient that how much he is dependent on nicotine, we will have to perform either Fager-Storm test, or we will have to review of 5 A's. What are these 5 A's? Ask every patient about tobacco use, advise all smokers to quit, assess smokers' willingness to quit, assist smokers with treatment and referrals, arrange follow-up. These are the 5 A's that every pharmacist must consider while assessing the nicotine dependence. Whereas Fager-Storm test is Whereas in the Fager-Storm test, it determines level of addiction. How soon after waking do you smoke your first cigarette? Time less than 5 minutes means 3 points. Time 5 to 30 minutes, 2 points. 31 to 60 minutes, 1 point. And how will you interpret this Fager-Storm test? If there is heavy nicotine dependence when the points are 5 to 6 points, moderate nicotine dependence when 3 to 4 points are there, and light nicotine dependence when 0 to 2 points are there. Now, tobacco dependence has two parts. The first is physical and the second one is behavioral. When there is physical one, it means there is addiction to nicotine medications we will use for cessation, and when there is behavior, we will consider the habit of using tobacco. Behavior change program or CBT, cognitive behavioral therapies, will be done. Treatment should assess both physical and behavioral. Starting from the pharmacotherapy of nicotine dependence, FDA has provided us with the first-line agents, which are further divided into oral agents and nicotine replacement therapy. Oral agents could be psychotropics like bupropion and partial nicotinic receptor agonists like varenicline. ठीक है, nicotinic replacement therapy. What is NRT? Basically, NRT helps those people who are in the process of quitting smoking. They provide the person with the drug nicotine they are craving for straight into the bloodstream without producing the harmful chemicals that smoking cigarette does. So there are some examples of nicotine replacement therapy. This could be nicotine gum, patch, lozenge, spray, or inhaler. Whereas second line agents are not FDA approved specifically for smoking cessation, but we can prescribe clonidine and nortriptyline. Now, moving towards the transdermal nicotine patch. Transdermal nicotine patch is applied to the skin and delivers nicotine through the skin at a relatively steady state. The patches stick onto your skin and help to absorb the nicotine through your skin in your bloodstream. Available in range of doses 5 mg and 22 mg. This is the complete treatment dose. ठीक है, लेकिन वैसे ही किस डोज में अवेलेबल होती है 5 mg and 22 mg. Advantage is great that it is patient compliance. Patient compliance हमें इससे मिलती है. Patient places the patch in the morning rather than actively throughout the day. Plasma concentrations higher compared to active formulations, and nicotine delivered more slowly. The thing that we have to tell the patient is the side effects. Local skin reactions हो सकते हैं, sleep disturbance हो सकती है with 24-hour patch. Also, we have to tell the patient that there is a continuous release of the dose, so he does not have to add the doses. Nicotine gum. Now, nicotine gum is the first NRT, transmucosally delivered nicotine proacrylic nicotine gum. It is not chewed like ordinary confectionery gum, but it is intermittently chewed. पूरी तरह नहीं आपने इसको च्यू करना ऑर्डिनरी उसकी तरह, but intermittently chewed and held in the mouth over about 30 minutes as needed to release its nicotine. 2 mg and 4 mg में ये अवेलेबल होती है इसकी स्ट्रेंथ. Acidic beverages, you have to tell the patient that he is not allowed to take the acidic beverages for next 15 minutes after the administration of nicotine gum. Now, So nicotine lozenge, it is very similar to the nicotine gum. It is also available in 2 and 4 mg strengths. Instructions are same, but the lozenge is not chewed. It dissolves in the mouth over approximately 30 minutes with same variation across individuals. Amount of nicotine absorbed higher as compared to nicotine gum. Alternative for patients who need intermittent controllable dosing and who do not find gum chewing acceptable, तो उनके लिए हम ये ऑल्टरनेट दे सकते हैं. मैकेनिज्म ऑफ एक्शन निकोटीन लॉजेंज का क्या है? निकोटीन फ्रॉम द लॉजेंज इज एब्जॉर्ब्ड स्लोली थ्रू द बकल म्यूकोसा एंड डिलीवर्ड इनटू द सिस्टमिक सर्कुलेशन. Now the adverse effects are this. We have to address the adverse effect to the patient. We have to tell the patient that there could be dyspepsia, hiccups, cough. So patient has to tolerate that, और मतलब उसको वो manage करेगा या हम उसको बताएंगे कि ये management करनी है. तो ये सारे adverse reactions हो सकते हैं. We have to tell this to the patient. We have to tell the patient as well कि 30 minutes he has to wait and let the lozenge dissolve in the mouth, and there could be a tingling sensation when he takes the lozenge. Now nicotine nasal spray. So nicotine nasal spray delivers doses of nicotine rapidly and absorbed into the blood rapidly as compared to any other forms of the nicotine. It is available as multi-dose bottle with a pump mechanism fitted to a nozzle that delivers about 0.5 mg of nicotine per 50 microliter. Each dose consists of 2 squirts, one to each nostril. Patients should be started with 1 or 2 doses per hour, increased up to the maximum of 40 doses per day. So there could be increase depending upon the situation or condition. Now, patient's education. Before using the nasal spray for the first time, the nicotine nasal spray pump must be primed. This is done by actuating the device into tissue until a fine spray is visible about 6 to 8 times. When administering a dose, the patient should tilt the head back slightly and insert the tip of the bottle into the nostril as far as is comfortable. After actuation of the pump, the patient should not sniff, swallow, or inhale through the nose because this increases the irritant effects of the spray. Patients should wait 5 minutes before driving or operating heavy machinery because of the increased likelihood of tearing, coughing, and sneezing. So nicotine inhaler, which consists of a mouthpiece and a plastic nicotine-containing cartridge, is there. When the smoker inhales through the device, nicotine vapor is released and deposited in the oropharynx and absorbed through the oral mucosa. Nicotine inhaler basically addresses the physical dependence and the behavioral sensory aspect of smoking. Its pharmacokinetics is very similar to that of gum, produces plasma nicotine levels that are roughly one-third of cigarettes. Nicotine vapor is released and deposited primarily in the oropharynx and then absorbed through the oral mucosa, does not reach the lungs to an appreciable extent. Frequency इसकी हमारे पास हो सकती है 6 to 12 cartridges per day for the first 6 to 12 weeks, followed by gradual reduction of dose over the next 6 to 12 weeks. Localized irritation of the mouth, there could be, or throat is common. Throat irritation is common, particularly during the early stages of use. So we have to tell the patient कि उसने बहुत shallowly inhale करना है puff को, minimize the throat irritation. There could be 40% throat mouth irritation and cough 32%. So in oral agents we have bupropion, which is a first line agent. हमारे पास bupropion एक atypical antidepressant है. It affects the level of brain neurotransmitters. Its mechanism of action is not very clear, but benefits in improving long-term abstinence rate and are not immediate and take several weeks or longer to be evident, but helps in smoking cessation. So clinical effects क्या है? Decrease करती है craving for cigarettes and symptoms of nicotine withdrawal. Bioavailability इसकी 5 to 20% है. Half life इसकी 21 hours है. However, इसके metabolites की half life 20 to 27 hours है, and it is extensively metabolized by liver, and excretion is 87% eliminated through urine, 1% unchanged, and 10% feces through feces. if you talk about the dose of bupropion, patient should begin therapy 1 to 2 weeks prior to their quit date, ठीक है, to ensure that therapeutic plasma levels of the drug are achieved. Initial treatment में you can give 150 mg per oral QAM 3 days तक, then 150 mg PO BID per oral BID दे सकते हैं. Duration हमारा 7 to 12 weeks है. They are saying if bupropion if जो है अगर आपको ब्यूप्रोपियोन का 7th वीक में रिजल्ट नहीं मिल रहा है, if no significant progress towards abstinence by 7th week, therapy is unlikely to be effective. Discontinue the treatment or reevaluate and restart at later date. It should not be given with to the patients with a history of seizure, with a history of cranial trauma, patients with severe hepatic cirrhosis, with depressive or psychiatric disorders. Now our second drug is varenicline. Varenicline was first designed specifically for targeting the nicotinic receptor, which are responsible for nicotine dependence. It produces its action at alpha 4 and beta 2 nicotine receptor. It is basically a partial agonist and antagonist. Releases lower amounts of dopamine into the brain than smoke. Stimulates low level agonist activity. It also reduces withdrawal, not as addictive as smoke. So its bioavailability same as that as bupropion, 5 to 20%. Half life is 24 hours है, and it is more effective than bupropion. इसकी absorption minimal है, इसका metabolism भी minimal है. Excretion 92% excreted unchanged in the urine. Varenicline basically is indicated as an aid for smoking cessation in adults over 18 years. The patient should set a date to stop smoking. Varenicline dosing can be started from 1 to 2 weeks before this date. Varenicline tablets should be swallowed whole with water, and tablets can be taken with or without food. Adverse reaction: nausea 30%, sleep disturbance, insomnia 18%, abnormal dreams 13%, constipation 8%, flatulence 6%, vomiting 5%. And we have to tell the patient this thing that he has to take the medicine with full glass of water. Then patients should begin therapy 1 week prior to their quit date. The dose is gradually increased to minimize treatment-related nausea and insomnia. So now we have steps to case workup. इसमें हमें क्या क्या देखना है? We have to first identify patient is in which stage or stage 2 model for change. We have to sign constant form, take his signatures on constant form, review 5 ways जिसमें आपका assessment वगैरह होता है पूरा, और एंड में आप अरेंज कराते हैं फॉलो अप. फिर फैगर स्टॉर्म टेस्ट है जिसमें आप पॉइंट्स की बेसिस पे डिसाइड करते हैं. दिस टेस्ट इज ऑप्शनल. Agree on behavioral modifications to make. If he agrees, then CBT पे चले जाएंगे हम. Then we will, if he doesn't agree or if CBT doesn't work, then we will decide the TC products, यानी कि जो medications आपने देनी है, first line, second line agents. हमें उसका ब्रीफ 5 फेज के बारे में लिखना होगा उसके और फार्मेसी में उसको सबमिट करना होगा. बीइंग अ फार्मासिस्ट, राइट स्क्रिप्ट, फिल एंड डिस्पेंस, चार्ज पेशेंट फॉर मेडिसिन काउंसलिंग. नोटिफाई पीसीपी. पीसीपी हमारे पास पार्शियल हॉस्पिटलाइजेशन रिहैब्स होते हैं कुछ, जो हमारे पास हेल्थ केयर टीम होती है, हम उसको नोटिफाई कर सकते हैं विद इन 15 days. इफ द पेशेंट की कंडीशन सही नहीं हो रही, देन कॉन्सेंट फॉर्म के थ्रू फिर हम उस पेशेंट को रिहैब्स में रिहैब्स भी प्रिस्क्राइब कर सकते हैं. And to see the SOAP note, it is very easy. We have to first end the subjective. We have to first write down the hours past infection, chief complaint, stage and quitting process, social history, past medical history. Then objectives में vitals और lab values आ जाती हैं. Assessment में triggers and associations, readiness to quit, product justification, plan में quit date है, specific pharmacotherapy and behavioral modifications. Behavioral modifications, PCP, healthcare team notified and date documented. So now we have case-based application. The case says a 65-year-old retired patient, John Smith, date of birth 10/22/48, comes to your pharmacy, appears depressed and have burning sensation while urinating, and he has not taken any medicine for the burning sensation, and he had several episodes of chest congestion along with the chronic cough. Smokes 1 packet per day for 15 years. He had open heart surgery back in 2012. Currently, he is taking beta-1 blocker 1.25 mg daily and salbutamol 4 mg for asthma. He is ready to quit smoking, but he is unable to do that. Being a pharmacist, how will you counsel John? What will you recommend? Write the justification-based assessment. Now we are preparing the SOAP notes for the above-mentioned case study. First, in the SOAP note, we will start from the subject. Subject says that he is a male 62 years old retired patient. Current condition shows that he appears depressed and suffering from UTI. Smokes one packet of the cigarette per day and for 15 years. Past medical history shows open heart surgery and several years back and recurrent episodes of chest congestion along with the chronic cough, that is asthma. Current medications he is taking are metoprolol, that is beta-1 blocker, and salbutamol, that is bronchodilator for asthma. Ready to quit in the next 30 days. Object: no lab test or vitals are given here. What will be our goal of the treatment? Lifestyle modifications, changing the habits, smoking cessation. The main goal is smoking cessation, but we will have to do first these two steps, then we will move towards the smoking cessation. Coming back to the normal neurotransmitter levels, it shows that we have to bring its body's normal dopamine levels. Moving towards the assessment, justification based assessment. Justification of recommended drugs. We haven't recommended any drug right now, but whatever the drugs we will recommend, we have to justify it with a number of treatment experiments or different logical reasons. Here we have taken some evidences from based medicine journal reported findings from 12 treatment specific reviews of high methodological quality. Vanicillin was superior to NRT monotherapy. Vanicillin was superior to bupropion. Vanicillin was not superior to combination NRT. NRT and bupropion were of equal efficacy. So what they are saying कि vanicillin हमारे पास जब NRT की monotherapy हम करेंगे तो उसमें vanicillin will be superior, but vanicillin was superior to bupropion as well, but vanicillin was not superior when we give NRT in combination. NRT and bupropion were of equal efficacy. Keeping in mind this justification or these experiments, we will suggest or recommend the drugs. And keeping in mind the current and condition and past medical condition, medical history of the patient, we will suggest the drugs. Moving towards Okay, so in the plan, step one is cognitive behavioral therapy, which will lead to or which will help us to achieve the first goal of treatment, that is lifestyle modifications. What is CBT or cognitive behavioral therapy? It is basically a psychosocial intervention that focuses on changing unhelpful thoughts, beliefs, attitudes, and other behaviors, and also improves emotional regulation and creates a suite of coping strategies to solve problematic issues, deals with the patient's those attitudes which he is unable to share with anyone. So the therapist talks about all the fears, all the things, all those thoughts, attitudes, and emotionally convinces. The therapist's job is to emotionally convinces the patient to quit smoking. So while doing the cognitive behavioral therapy, we have to keep in mind some of the backup plans, and these backup plans involves if the patient slips or if there is relapse, then what will be our plan of action. So there must be slip versus relapse plan of action, a smoke break plan of action, crisis plan of action, avoid triggers and associations. This is what the duty of a therapist who is doing cognitive behavioral therapy or there is somewhat cognitive behavioral therapy can be done through the pharmacist as well. There are some of the pharmacists who are specialized in counseling in cognitive behavioral therapies, and they can also do this therapy. So what we have to keep in mind, we will keep in mind the relapse action, backup plan for slip versus relapse, smoke break, crisis plan of action, avoid triggers and associations. This should be step 1 of the plan for Mr. John. Step 2. Usually we recommend step 2 is NRT, nicotine replacement therapy, which includes gums, patches, lozenges, and other things. But here we cannot recommend an RT either singly, alone, or in combination, monotherapy or combination therapy. We cannot recommend here to Mr. John. The reason is this: Mr. John has Mr. John already had open heart surgery, and he is also suffering from asthma and UTI, and we know this that NRT is very much very much affects and contraindicated in UTI, asthma, myocardial infarctions. However, once it is given, it can cease smoking, but we cannot give gum or any other NRT here. Instead, we can give first line agent here. We cannot even give nasal spray because it is avoided in asthma or COPD or URI diseases, and NRT is also associated with the UTI. So here we are not going to follow the step 2, and we will move towards step 3 directly. That is, we will have to go for smoking cessation through first line agent, that is bupropion, with or without NRT. यहाँ पर इसका कॉन्सेप्ट हमारे पास क्या है कि it is based on risk benefit ratio. If it does not work, then we will have to follow NRT. NRT में भी वो चीज़ हम फिर देंगे जिसके मिनिमम साइड इफेक्ट्स हैं, जैसे कि गम एक तो एल्डरली पेशेंट्स में इजी होता है देना, फिर इसके मिनिमम साइड इफेक्ट्स होते हैं. इट कैन सप्रेस द एपेटाइट, बट हेयर वी विल ट्राई आवर बेस्ट नॉट टू गिव NRT, so it will be without NRT. We have other options as well. First of all, the dose of bupropion will be 150 mg daily uh, for 3 days, and then BID. BID, as it is the safest among all and shows no interactions with salbutamol, and will help Mr. John to reduce the cravings leading to smoking cessation. Right, then we have another option as well, that is varenicline, but we cannot recommend varenicline here. Why? Because it is contraindicated in any kind of depression and anxiety. However, it is more effective, as we already studied before in the justification based assessment, that varenicline is more effective than bupropion, but we cannot recommend varenicline here. But later on, if bupropion does not work and Mr. John continues to smoke, which may worsen his heart, we will have to start varenicline, considering the risk-benefit ratio 40/60. 40% अगर risk है और 60% हमारे पास benefit है, then हम इसको consider करेंगे कि हम benefit ज़्यादा मिल रहा है, तो we will start giving varenicline. But first हमारी क्या कोशिश होगी कि इससे हमारे पास हमारा ट्रीटमेंट हो जाए. Now moving towards the plan summary, summarizing the treatment of Mr. John. ठीक है, we will start from CBT, cognitive behavioral therapy, which will be continued for 1 month. Monitor improvements. If only CBT helps Mr. John in quitting smoke, we will not have to start any other medication. Right? Ask Mr. John if he feels deprived. अगर वो cognitive behavioral therapy के बाद भी deprived feel करते हैं और craving होती है उनको, craves more than, this is more than THAN, more than, we will have to more than before, THAN अगर होगा तो more than before, we will have to start bupropion. We cannot use NRT here due to Mr. John's current condition. ठीक है, ये मैंने पहले ही explain कर दिया था. And other comorbidities. Bupropion has 99% chances to cease smoking, but for any reason, if it fails, then we will start with varenicline. But right now, we cannot prescribe varenicline as it is contraindicated in depression and anxiety. Duration of the treatment with bupropion will be for 12 weeks. Bupropion may help in reducing associated depression. If he is not diabetic, he can be given Cranmax for UTI. But you don't have to deal here with other comorbidities. लेकिन अगर हम देना चाहें और वो diabetic नहीं है तो हम उन्हें Cranmax दे सकते हैं. We have to counsel Mr. John as well about the bupropion. He can take bupropion in an empty stomach or with food, because here we are using SR bupropion or SR bupropion or XL. So but we have to tell him that he should not chew, crush or break it, so that the medication can work correctly in his body and reduces the risk of serious side effects. Now, what is the pharmacist perspective authority protocol highlights? हम बताएंगे इसके अंदर. तो हमारे पास क्या है कि काउंसलिंग जो करनी है फार्मासिस्ट को वो 90 मिनट्स पर पेशेंट करनी है, और उसने फॉलो अप लेना है पेशेंट की पास मेडिकल हिस्ट्री का, सोशल हिस्ट्री का, अप्रूव ट्रेनिंग, प्रिस्क्रिप्शन करिकुलम के हिसाब से देनी है उसने, prescribe FDA approved medications only, informed constant approval to notify PCP in 15 days of prescription if identified. What they are saying कि हमें जो है constant approval को यानी कि हमें अगर कोई ऐसा patient आया है pharmacist के पास that really needs a rehab, this PCP is basically partial hospitalization रिहैब सेंटर्स कहलाते हैं ये. तो ये जो पीसीपी होते हैं, अगर हमें उसे 15 डेज के अंदर अंदर प्रिस्क्रिप्शन देख के अंदाज़ा हो रहा है तो हमें अप्रूव उसका कॉन्सेंट या उसके घर वालों से कॉन्सेंट चाहिए होगा फार्मासिस्ट को. फार्मासिस्ट मस्ट रेफर, अगर वो फर्स्ट लाइन ऑफ एजेंट्स में bupropion कर रहा है तो ही कैन नॉट गिव दिस ड्रग इन सीजर डिसऑर्डर, ईटिंग डिसऑर्डर, alcoholism, liver cirrhosis, contraindication to specific therapy, NRT, arrhythmias, MI, angina worsening. Varenicline depression और anxiety में नहीं दे सकते. Risks are greater than benefits, right? So this was the end. This was the whole of my presentation, and now here I am ending my presentation. Thank you for listening it. Thank you so much. Allah Hafiz.